Yes, usually we know that every patient, you and me also, when considering a drug, if you have a DH, would you prefer to inject a non-steroidal anti-inflammatory drug or to take a pill? Obviously, patients usually prefer to take a pill because it's easier. And also because having a pill reduces the burden of treatment, because there is not only a overall burden of disease, that is a clinical burden, a psychological burden in patients with hereditary angioedema, but there is also a burden of treatment related to the pain of injection, related to the fact that you need to carry with you injectable drugs that are not easy, example, when traveling, and many other reasons. And thus, oral tablets reduce this burden of treatment and make easier and earlier the treatment. No special plan for transition. You ask only patients. You have naive patients, and usually naive patients prefer to start immediately with oral therapies and not with injectable drugs. But in case of patients who used them in the past, that are the majority injectable drugs, you just inform them that now we have a very effective and safe oral therapy, and we propose them to start the new therapy because easier and effective at the same way as previous therapies, injectable therapies. No, maybe that's the question is if there are still patients preferring injectable therapy.
Yeah.
Yes, maybe that also. Usually, the only reason that I do not think that patients prefer injectable therapy. No patients overall prefer injectable therapy, but in patients' opinion, maybe they feel that an injectable therapy is more effective than an oral one, because as example, if you are admitted, if you go to the emergency room, they usually inject you drugs. They don't give you a pill because you have a pill at home, obviously. And in this case, the only issue is to explain the patients, to make the patients confident that this oral treatment is as effective as the previous injectable drug, and that we have clinical studies showing that is so. It's not just a matter of personal opinion, but we have scientific data from clinical study showing the efficacy and safety of the new therapy. And thus, the only reason was this, that some patients may still suppose that an injectable drug is more effective than an oral one, but it's not so. And usually all patients involved in clinical trial in my cohort, in my university, have been very happy, and they are still using this drug as a compassionate use, because the drug is not yet approved in Italy, because the company is negotiating the price with our authorities at present. But anyway, we can provide patients who are included in clinical study the drug, and we have no withdrawal, no patients who discontinued this opportunity, because the drug is effective, safe, and easy to take, and without any significant adverse effect. In my opinion, there is not a huge limitation in interpreting the data. Obviously, clinical trial select patients, they do not reflect, but it's true for any clinical trial, not just for the KONFIDENT trial. They do not reflect the real life, and that's because we have selected patients with fixed, well-established number of attacks. We know anything about these patients, and these patients are usually healthy patients, but for the disease we are considering. But anyway, the results are the study has been designed very well, and we have no difficulties in explaining both to colleagues and patients the results of the trial, because the results are easy to understand, and more important, they are strengthened by the open label extension study, showing that in real life the results are confirmed, and also that in real life the delay is also less than in clinical study. That we have no concerns for the future. The best, the most important real data will be not safety is the more important in real life, but anyway, we have no concern about safety of this acute treatment. But the most important real data is confirming that the efficacy of the treatment is long time. There is not any sort of tachyphylaxis, and also that in real life, as showed by clinical trials, that the drug is effective in the same patients on different attack location. It means that, for example, it must be effective in laryngeal attacks, in peripheral attack, but also in abdominal attack. We had some concerns at the beginning, because probably you know that not the majority, but a high percentage, a high proportion of acute attacks of angioedema affects the bowel, stomach, gastrointestinal apparatus. In this case, we had some concerns at the beginning on the efficacy of an oral tablet in patients with gastrointestinal complaint. But we know now that the drug is effective also in this case. Thus, what is more important for the future is long-term confirmation in the same patients of the efficacy of the drug. The absence of rebounds, because we know that with some drug, for example, icatibant, that is the most used injectable therapy for on-demand treatment, around 20% of patients experience a rebound of the attack, and they need one more or two more injection. And this seems not to be the case with Sebetralstat. Sorry, which?
What unanswered questions remain with Sebetralstat?
Okay. Of course, the drug is allowed for adolescents aged 12 and more, but now we are obviously there are clinical trials addressing also children. That means population between 2 and 12, and this is also more important because they need oral therapy for acute treatments more than the adults, because the burden of treatment is higher in children, and there is also a psychological burden for caregivers who usually are the parents of children, because they have a fear to inject the drug to their children. They fear they know that the injectable drug are painful, the children may cry, and so on. And thus, having the opportunity to treat acute attacks in children by oral therapies will reduce the burden of the disease, the burden of treatment, and there will be one less unmet need that we actually have in this age range. The takeaway is that the future the present is the opportunity to treat acute attacks by oral tablets, which allow to treat early, to reduce the duration, and to reduce the severity of symptoms, because only early treatment allows patients to be adherent to the guideline and to normalize their life.